following is a local resident producers program. The program content is the sole responsibility of the producer and does not necessarily reflect the views or policies of CATV2, Oshkosh Community Media Services, the City of Oshkosh, or Time Warner Cable.
Hi everybody, welcome to Eye on Oshkosh. Cheryl, Hentz, and Dan Rylance here, and very pleased to be joined this evening by two folks from the Affinity Visiting Nurses Hospice Association. You know, Dan and I have both been, we've had family members who have had to use hospice. Dan just fairly recently, and me about 4 years ago. We keep hearing about so many people that we know coming down with cancer and so forth. So we just thought it was a good idea if we had some folks from hospice come in, talk about what hospice is, what it does, and then we're also going to discuss bereavement, because that's obviously a part of end-of-life issues. So very happy to welcome to the show Karin Meier. She is seated to my left, and she's the hospice director with Affinity Visiting Nurses Hospice. And to her left is Melissa Greft, who's the bereavement coordinator for that same organization.
Welcome, both of you.
Yes, thank you both for being here. We understand there were some scheduling snafus and so forth, but we're happy that you guys were able to work it out to be here. So,
well, thank goodness the weather. You know, we don't have snow yet, so
yes.
we couldn't. That
the
wasn't
little bit
a problem.
we did have
so,
melted,
yeah,
so we're in good
we're
shape.
Glad to be here.
Great, thank you. One of the things, you know, we want to certainly talk about what hospice is, but how did you guys come to work in hospice and bereavement? Maybe you can just give us a little brief background on, you know, how long you've worked in this field, and you know how you came to work in it.
I'm a nurse by background,
Okay.
and so I'm a registered nurse. My love and passion for a few years was working in the critical care arena. And so I worked with trauma patients, patients very, very critically ill. And lo and behold, before I realized what was happening, I was being drawn to those patients who had a very, very serious illness, and maybe families were struggling with decisions. Maybe their loved one was on a ventilator. Maybe, you know, there was decisions about whether to continue very, very aggressive treatments or a more palliative approach. And when I saw myself heading in that direction, I was quite surprised by it. But before I knew it, I was working on an inpatient palliative care unit. From there, I went from a staff nurse into management and then into the hospice arena. Mm-hmm. So it was what I saw as options for people in healthcare today. There's some very, very tough decisions people have to make. There's wonderful treatment options, but we're all only here for a period of time. Mm-hmm. We're not meant to be here forever. And so I wanted to see that quality time at end of life. And so that's why I chose hospice care.
Okay, excellent. What about you? How did you get into bereavement?
I started off actually in my undergrad here at UWO, and I wasn't sure exactly what I wanted to do with it. And it was a human service major, and I was a CNA, and then prior to that, I had worked with younger children because I wasn't sure quite what age group I wanted to work with, actually. And when I was a CNA working in the nursing home setting, I would see the families at the end of life when their loved one was dying, and I kept thinking, I want to do something more. I want to do something to help them. And I actually found a wonderful program at Meier that was in grief and bereavement for my master's, and that's how I wound up with hospice then, because I love what I do, and I love being able to help those families at the end of life and help them through the first 13 months of the loss of their loved one. So that's how I that's how I got into hospice.
Great. Well, it's got to be tough. You know, you see a lot of very sad, tragic kind of situations, and yet what you do is providing such a huge benefit to families like we've all had to deal with at one time or another, and that's got to be the reward which offsets the sadness of what you're dealing with.
Well, what we see, there's nothing else like going through that process of your loved one dying. It's exhausting. You know, we all put in a 40, 50, 60-hour work week, but being with your loved one and maybe caring for them in your home is exhausting. But yet it's such a special time. And that's where hospice can come in to help through that period of time, help with the, you know, the symptom management or the teaching. There's so much teaching in hospice care. And then providing that emotional support. One of the least used important parts of our body are our ears. We need to listen to each other. We need to listen to concerns. And that's what hospice can add to that. Because it is tough. But then what we take away from it is how important life is. And laughing through the little things. We were just waiting for this program, and she was talking about spilling things on her white shirt. Well, that's what Grandpa did. Well, at first when that happens, you know, it brings tears to your eyes. It's like, oh my gosh, I don't want to go there because this reminds me of Grandpa, or this reminds me of my spouse that just died. But in time, yeah, you can spill and look down. And as she shared, she laughed because that's what Grandpa always did.
Yeah. You mentioned palliative care earlier, and that's something that we often hear associated with hospice care. So talk to us a little bit about what the difference is between palliative care, and then we can move into what hospice is and what you folks do.
You want me to go ahead?
Go ahead.
Life is a transition. An end of life should be a transition. So I see it as you're diagnosed with a bad disease. And you know, we always talk about cancer, you know, kind of cancer and hospice go hand in hand. But what about end-stage lung disease? I mean, all of us probably know somebody that has COPD or emphysema or heart disease.
Or Alzheimer's.
Or it's Alzheimer's, as you shared with us.
Yes.
Well, you plug along, and do I want to get fixed? You bet I want to get fixed. I want my, you know, whatever to go away. But you know what? There comes a time when it's starting to hinder, you know, your everyday, you know, living, your ability to be yourself every day. Or maybe you're having to go into the ER often, or maybe you're having to be hospitalized real often. So, you know, let's take that bad lung disease. You know, you get oxygen at home, but you're doing okay, and you're doing okay. But then all of a sudden, you're going to that ER, you're going to wherever. That's when palliative care can step in. Palliative care combines more aggressive, curative treatments, but starting to talk about, you know, managing those symptoms that are bothering you, and starting to talk more about, do you want to do an advance directive? Have you talked about, do you want to be put on a ventilator someday? Have you talked about, do you want continued aggressive care? So it's a transition. And then hospice comes on board when you've made decisions that you want to opt for more of the hospice philosophy, the more comfort care. And that's when we get into that 6-month prognosis. And that's confusing for people, and we can maybe go into that later.
Sure, yeah. So hospice is dealing with people who are terminal or close to being terminal. Okay. Yeah, let's talk about that process. Let's start there, because I'm sure that some folks will readily accept something like hospice and the services you provide. And we're going to discuss those too. Others, whether it be family members who don't want to accept what's happening, or the patient themselves who can't really wrap their head around it, or they just flat out don't want to deal with it, which was the case with my partner's mother. You know, she did not want to have anyone come in, period. You know, she just said, I'm not having anybody in here, period, that's it. But then, as things progressed and she became a little more ill, she recognized that she needed someone in. And she became very close to that hospice care person.
Yeah.
And toward the end, she referred to her as an angel in disguise. And it was interesting to see the transition that she made. But let's talk about that 6-month diagnosis, which is very misleading, as you said, because that's what we were told, and it turned out not to be 6 months. It was, I think, 4.5 months, something like that. So why do they usually say 6 months? I mean, where did that ever come from?
Came from Medicare.
Okay.
Medicare, who the majority of our patients are Medicare age, but we do treat everyone from infants, maybe newborns, with a poor prognosis, facing that infant dying, all the way through the elderly. But hospice Medicare benefit, they put a 6-month criteria on it. Now, why and where, that came about. I wish I could say it was before my time. It wasn't. It wasn't that long ago. But they looked at the 6-month prognosis because, they had to put some time limit on it. So when we go out and do a consult or a referral to get somebody onto hospice, we have to measure criteria to see if they're eligible for hospice or not. And so, for example, you were sharing you have a family member with Alzheimer's disease. We have a listing, it's called an LCD, and our admission coordinator goes through and has to find criteria that 2 physicians then have to document and verify that yes, this person has a prognosis of 6 months or less. Well, you can say, well, who's got that crystal ball? I've never seen that crystal ball. But there are certain things. So that person with lung disease, we look at their pulmonary function tests or their lung tests or their oxygen levels, that sort of thing. So that's what we measure. Somebody is with Alzheimer's disease, we have to measure how many words can they speak? Can they help care for themselves? How many words are, intelligible, that sort of thing. So that's what we have to measure to look at that 6 months. But what we found is, just like what you said, that 6 months is quite often so much shorter. And people aren't on hospice long enough because they wait. Well, they can go to the grocery store. They go out to restaurants. They go to the park. They see their grandkids. They're not ready for hospice yet. They're not dying.
Right.
But then it gets to be too late sometimes. And that's our challenge, and that's why we're so grateful to be here, to share that word, that don't wait till the final few days. And then the other flip side is, sometimes we have people on hospice much longer.
Years.
Because you know what? They get on hospice, and their medications are well managed. Their symptoms are finally under control. They're not huffing and puffing, to get to the car. And so they do better. But then every so many days, and again, it's a Medicare guideline, every certification period, we again have to certify that, yep, they're eligible again.
Okay.
So I don't want to make it more confusing than it is.
I want to turn to financial questions a little bit. Is yours a not-for-profit program or a
Yes,
profit?
it is. Not-for-profit
Okay.
program.
Do you have a full-time physician or medical director with? Okay. Who pays for hospice? Can you kind of go through that a little bit?
Sure.
Okay.
Medicare,
Okay.
Medicaid,
Okay.
and most private
Okay.
insurances.
What if the person has neither?
Because we at Affinity Visiting Nurses are a part of Ministry Healthcare,
Okay.
Which is a non-for-profit, and we will accept anyone,
Okay.
no matter what their income level.
Okay. Now, correct me if I'm wrong on this. I also was reading that if a patient goes for Medicare A, the person has to opt out of getting reimbursement for other Medicare A programs. Is that correct?
Yeah, depending, and it's on a case by case.
Okay.
So.
Can you give me an example of how that? I'm
Yeah. Say a person is on hospice for, I'm trying to think of something that won't get too complicated. Say somebody is on hospice for the lung problems.
Okay.
You have COPD, end-stage lung disease, and you fall and break your hip.
Okay.
Okay.
My mother-in-law broke hers too.
Okay, I'm sorry.
You're psychic.
I don't have that crystal ball.
You're fake.
We again, it's a case by case, but we look at that case, and what hospice is covering is everything related to that lung disease,
Right.
because that's their terminal diagnosis. Now, the hip fracture wasn't related, but they would be admitted to the hospital, go in, decisions would be made, is that hip repaired, do they need surgery, whatever. That would be billed differently.
Okay.
So that would be taken care of. Now, if it was a disease that the fracture was related, so maybe they have a cancer diagnosis, and they can have the metastasis to the bone, well, then that would be a different scenario. So it's different for everyone.
Just one more one. All hospice programs are not the same, are they? So some, or are they?
Very, very similar.
Very similar.
I would say very similar.
Okay.
Uh-huh.
Okay. What would be a different hospice service that one would offer that one would not?
I mean, some hospices are able to provide some complementary therapies,
Okay.
Like pet therapy, music therapy, that sort of thing.
Okay, gotcha.
Some are for-profit. Some focus more on, we care for a person no matter where they live, whether it be a nursing home, a CBRF, their home, their loved one's home. Some hospices focus, more at facilities than others. So there's little differences.
This question should have been asked at the beginning, but Cheryl was doing so well with the introduction, I didn't want to interrupt. But I asked a social worker, retired social worker, about you people being on the program, and what question would he suggest that I ask? And it's and his question and my question to you is, what sort of person seeks work for hospice, and how do you cope with taking care of patients and watching them die? Now this maybe is good to her.
I think that, a person has to be really compassionate and caring and wanting to help people.
Okay.
We're a helping field, and I think that's why we all get into the healthcare profession, is because we want to help people. At least, I guess I'm speaking probably for myself, but that's, I wanted to be able to help people more than what I was. I wanted to be able to go in there and help them at the end of life. And, how do we cope? I always tell people, I probably sound crazy when I say it, but I love what I do, and I'm so passionate about what I do that when the deaths occur, I'm watching these families, but I know that I'm going to be helping them.
Okay.
I'm going to help them through this. So my coping is maybe a little bizarre, because it comforts me knowing that I get to turn around and help them.
But it's much easier to work with patients knowing they're going to get well, as opposed to working with patients that are going to die, right? I mean, that's tough, isn't it?
When I interview people, I am looking for that something unique and special.
Yeah.
It is empathy, and it is wanting to help, but it's also knowing boundaries. Because you can get so overwhelmed and so attached and give. And so, you do have to be the kind of person, and we have to work, as a hospice team, because we are walking with that family through this journey. We're not tugging them along with a rope, because every case is so different, and that's what I've found over the years. And that's where a social worker, they're fascinating. We sit around at a table like this, with Melissa's bereavement, and a social worker, and a chaplain, and a nurse, and the hospice aide, and volunteers, and the volunteer coordinator, and we talk about cases, and each and every person brings something so very different to the table, because I'm a nurse, and she has bereavement, and we are helpers, But you can't fix everything either.
Right.
And that's what a social worker brings, to the table. That, maybe this person has lived this lifestyle, or this couple's had this relationship for 30 years. And so we work with that. because that's them.
She didn't flinch at all on the first day. She was on her feet were on the ground. That wasn't a problem, was it?
Nope.
No.
You know, Dan asked about different kinds of services that hospice provides, you know, as they differ from hospice organization to hospice organization. You know, and that kind of leads into a question that I have. So many times people, they don't really understand what hospice is, and they think, in fact, hospice is a place. Now, in your case, it's not a place. You care for them in their home or whatever living situation they're in. But I have seen in other parts of the country, and maybe we even have something like that in Wisconsin, where there actually is a hospice facility.
Yes.
Where patients go to end their lives, in most cases. But that's not what we're talking about right here with Affinity's Visiting Nurses Hospice, right?
With Affinity Visiting Nurses, we currently don't have a hospice house. As Ministry Home Care, we have 2 of them. We have one up in Woodruff, and then we have one in Marshfield.
Okay.
And so as a whole ministry, we have 2 hospice houses, but here in the Oshkosh-Appleton area, we currently don't have one.
Okay, good to know. Yeah, thank you.
Yeah, and we do serve people within approximately a 40-mile radius of our Neenah office. Our office is actually located in Neenah, just off of Highway 41. And then we serve an outline area of approximately 40 miles. So we just south of Oshkosh, and over to Ripon, and then up 49 and up north of Appleton, and over on the other side of the lake to Calumet.
And I will just tell the audience that because we're a non-commercial station here, we can't steer anyone in any one direction. A lot of people's insurance covers Affinity, who these wonderful women are with, but if yours doesn't or whatever, you have free choice. You can go to any hospice organization that you want. The main thing is to seek them out. But their website is www.affinitywisitingnurses.org, and there's also another website address that we'll be putting up, just a general national type website. I believe it's hospicenet.org. And you can find all kinds of resources there as well, including places in your area that offer hospice services. So, do we want to move into hospice services now and talk specifically about what they do?
What's your caseload over the last 5 years? Where are you at? Are you more, less, even?
We're variable. It does vary. As was said, though, I mean, we just want people to hear about hospice care, and I think more and more people are talking about end of life issues. I've been doing this for, like I say, over 20 years, and so the term palliative care, 20 years ago was very, very new, and the term hospice was equated to dying. I was sharing with Melissa. My mom lived in an elderly housing complex, and if the term hospice was said, the men would start whispering, "It's time that he gets his suit cleaned," because and we don't hide the term death. We don't hide it, but it breaks. What breaks our hearts is when we see people get on hospice really, really late, and we're not able to develop that rapport, or Melissa's not able to go out and meet the family or meet the children whose daddy's dying. That's what's tough.
The other misconception with hospice that I found out is it's equal to cancer. It's only the treatment, and that's not accurate either.
Yeah. Well, as you found.
Absolutely. But I wasn't sure about
It is
that.
a big misconception.
So, you've kind of alluded a little bit to some of the services that you provide, and maybe we can start by talking about the hospice team and what each member does, and that will kind of give viewers, I think, a pretty good idea of what services you provide. You mentioned the team members. Now, let's see. You've got a nurse, you've got bereavement, you've got a chaplain, and you've got a social worker. Did I pass that test?
Home health aides.
Okay, well, that wasn't even mentioned. Karin,
and a
you need
volunteer
nurse?
coordinator,
Okay.
And
All
they're
right.
so important, let me tell you.
and then our admissions coordinator.
Okay. And so let's start at the top. What does each person do to bring? What do they bring to the team, which ultimately is taken to the patients?
I think that the nurses bring the making sure that they're comfortable, making sure the pain is managed, making sure the patient is overall managed. The social worker can bring to the team that, how is everything going? Do they have that advance directive? Do they have the POA, and is it ready to go if it needs to be activated? So the social worker is kind of the behind the scenes person who does a lot of the
And
That
what are the
kind of
goals
stuff.
of care? What
Yeah,
are the
the goals
goals?
of care.
Talking about the what ifs, or well, what do you think? What are we going to do in the next
Yep.
few days, weeks, months? Yeah.
And then the home health aides can come in and help with, the bathing, the light housekeeping, the things that might not be able to be done anymore by the patient. And volunteers can come in and help relieve some of that caregiver stress, I guess I'll word it as, because when we care for our loved ones, we can get overwhelmed and just I need that hour break that I can go out of the house for that hour, and the volunteers can come in and provide that hour for them to
So
do
a
that.
little bit of respite there.
Yeah, and then the chaplain comes in and provides the social or the spiritual piece for the hospice team. And then the admission coordinator puts it all, they get the person on board. And then me, the bereavement coordinator, I come in, as soon as the patient's admitted, I'm part of the team, I'm on board with that patient. And I follow the family for 13 months after the death happens. So I get to follow the family for a long time, and that's probably, I love that part. I love being able to find out how things are going and how they're doing. And so I follow them with, bereavement mailings, I follow them with phone calls, I'll go do visits, and I do support groups. And, the support groups are open to the community. We have a wonderful men's night program that's just for men, where men can come up to our NINA office and just share their story.
Now, why are men singled out? Is it because they process their grief differently?
A lot of the times when you get a group together and you're talking about your loss of a loved one, the men tend to kind of hold those emotions inside because they feel, we have those stigmas, I have to be strong, I can't cry, for men, that's kind of put into their brain that I can't do this and I can't do that. So when you get a group of men together, they feel more comfortable saying, it's a group of men, I can be me. I don't have to put up that safeguard and not cry and not show my emotions.
Okay, all right.
It's a pretty profound group to see.
It's a wonderful group.
Yeah, I bet it is.
Yeah.
Now, the one medical healthcare person who I didn't hear mentioned was a doctor. Doctors, you're in constant contact with the patient's doctor, though?
Yeah, and we want to be clear. If Dr. Jones is my doctor, Dr. Jones will stay my doctor on hospice, but it's enhanced by our medical director. And I should have also mentioned too, we also have a nurse practitioner on board now. And so the nurse practitioner goes out and does assessments, follow-ups. It was wonderful addition to our team. And that enhances that care too. So you actually have 2 physicians and a nurse practitioner plus the rest of that team.
Sure. We're down to about 4.5 minutes left in this segment, and I told you it would go fast. And I feel like there's still so much more that we could discuss, but you mentioned advance directive before, and I certainly want to be sure that we get this information out. An advance directive is what?
An advance directive is putting your wishes known on paper. And so that is so key, whether you're looking at end-of-life care, hospice care. The most important thing is to talk to your family members about what your wishes are, but an advance directive is putting those wishes on paper.
And
Is
it's
that
not
different than a medical power of attorney?
Yes, yes.
You would recommend having medical power of attorney too?
Yeah, yeah.
Sorry, I didn't mean to.
No, that's
Yeah.
fine,
But-
but that's a good point.
Yeah.
And just because the word attorney is used, or because these are legal type documents, you do not have to, I don't want to take business away from an attorney. If you want to go to an attorney and have these things drafted up, that's certainly fine. But they are online. I think the state of Wisconsin has them online. I'm sure that their website has them online. And you can draft them yourself, and you might have to have them
Yeah.
witnessed or notarized.
Notarized, signed.
Yeah.
But
Yeah.
they're very simple to do. And in fact, even when you go in just for surgery these days, they ask. That's one of the questions that they ask. Dan and I are both very familiar with this, having had surgery this year.
Yeah.
They'll ask right away,
Yeah.
do you have one?
And the key too is talk. And we're not so much talking about death, or even talking about hospice, but talk to your family. Talk to your family about what your wishes are. It's so important.
Sure.
It really opens up avenues, and good avenues.
If someone has a loved one, or perhaps they themselves are dealing with some of these end-of-life type issues, they're not sure if hospice is for them or not, but they're seeing this program and thinking, maybe. Can they, even though they're not at that point yet where hospice may be needed, can they call, have someone come out and talk to them? Or can they come to an office and speak to someone just to kind of get more information and then make a decision as time sort of ticks on?
Yeah, they can certainly call the office, ask for the admission coordinator or a social worker. That's a really good option. Or talk to their physician maybe the next time they go in for a visit, and start that dialogue. But yeah, there's lots of information, lots of resources out there.
Okay, all right. Do you have any final short type questions or?
Family help with funeral arrangements a little bit. Maybe you could hit on that. I assume that's part of what you do? or-
Actually, the social workers work with the families. That's part of what
Okay.
they'll do. They'll help them make those final arrangements, make sure that we have a funeral home
Yeah.
set up, make sure that that's the biggest struggle I hear with patients is the overwhelmingness of
Sure.
of all of that, because it is a lot to go through and get the flowers, the casket,
There's options with
everything.
cremation, with
Yep.
donated cadavers to
Yeah.
medical
Yeah.
schools. It's
Yeah.
just not just
That's-
the old
Yep.
way where
Yep.
you just,
Exactly.
and the social workers will work with
Yeah.
each family and abide by what the wishes of the family are. So
Okay.
And then the piece that Melissa does is, if there's children involved, what do we tell the children? Grandma's sleeping. No. No.
Please don't tell them that.
But people used to, and they do things innocently.
Yes.
And that's the thing is, people aren't doing things or saying things to be mean or vicious. Typically, I mean, there might be those people out there.
Yeah.
But to have somebody like Melissa or somebody like a bereavement coordinator or a social worker to help answer some of those things.
Okay, great.
And typically the children ask the things that those of us as adults want to ask, but we don't dare sometimes.
Right, okay. Well, very good. Well, thank you so much for being here.
Very
And
informative.
again, you can check them out at affinitywisitingnurses.org, hospicenet.org, or you can call Affinity at 1-866-236-8500. That's a toll-free number. So, but don't put it off. Wherever you choose to go, do something because it is important. And time has a way of sneaking up on all of us, and it goes much faster than we often think. So,
Amen.
thanks again for being
Okay,
here. Just sit
thank
tight.
you for
We're going
having
to take a
us.
very short break, and when we come back,
Thank
we're
you.
going to
It's
talk
great.
about how to deal with grief and loss during the holiday season. We'll be right back.
Every year, the U.S. Department of the Treasury receives about 1.4 million reports of problems with paper checks. Checks can be lost, stolen, or delayed. If you still receive Social Security payments by paper check, Treasury wants you to know about a safer, more convenient way to get your money. the Direct Express Prepaid Debit MasterCard. The Direct Express card is new and is available to anyone receiving Social Security benefits, even if you don't have a bank account. Your monthly benefits will be automatically placed onto your card account each month on the day your money is due. While other debit cards cost money, it is possible to use the Direct Express card for free to make purchases, pay bills, and get cash at thousands of locations nationwide. There are no sign-up or monthly account fees. No more waiting for the mail or worrying about lost or stolen checks. Call 1-877-212-9991 or visit www.usdirectexpress.com.
And welcome back to the second half of Eye on Oshkosh. And before the break, I mentioned that we were going to be talking about how to deal with grief and loss during the upcoming holiday seasons. We've all, I think, seen the Norman Rockwell picture of the very festive, Christmas scene. Family all getting along and everybody happy and just having a great time. And we've also seen TV commercials with presents galore and everybody once again getting along. And while that's very picturesque, that's not always reality. In fact, more often than not, it's probably not reality. And this time of year, whether you're celebrating Christmas, whether you celebrate Hanukkah, Kwanzaa, or just winter solstice, this time of year can be kind of a tough time for folks. People suffer loss, as we talked about in the earlier segment. People may have a loved one away in the military. People may have suffered the loss of a pet, as I suffered too this year. People may have lost their jobs. This year in particular, we have an awful lot of folks who have they're suffering the loss of a lot of disposable income in their homes. So there's a lot of things that people are dealing with this holiday season, as in most holiday seasons. And to help us kind of sort through some of this stuff and talk about how we can still enjoy the season in whatever way we celebrate it and try to enjoy it is Brian Tokoph. He is a retired pastor and a retired chaplain, and he's I don't know how long you've been here in the area, Brian, but you're going to tell us a little bit about just a little bit about your background, and then we're going to talk about some of these very weighty and difficult issues that people are dealing with. So welcome. Thanks for being here, first of all. And
thank you.
Tell us about yourself.
Gee, where do I begin? Just at the beginning, huh?
Yeah.
I grew up in Chicago, was educated in Chicago, went to Northeastern Illinois University, and my goal was to go to seminary after I got out of university. Was married in 1979. Then I went to Northern Baptist Theological Seminary in Lombard, Illinois. I ended up in Wisconsin, and like I say, I grew up in the inner city of Chicago. I was called to my first church in Fond du Lac, and it was an American Baptist church, so I served there for 5 years. And at that time, near the end of my pastorate ministry at the First Baptist Church in Fond du Lac, I went to part-time as a chaplain at St. Agnes Hospital.
Okay.
So that's where I started my journey, you might say, as a chaplain.
So did you kind of work then as part of a hospice team also?
Oh, let me get into that in just a minute. When you're as a chaplain, you have to be licensed. You have to be, when I was in seminary, in graduate school for my Master of Divinity degree, you have to do what they call clinical pastoral education, which means you basically work in different units of the hospital, the clinic, the emergency room, hospice, you're on call, so you deal with crisis, a lot of stress, awful lot of stress all the time. 8 hours a day, even more when you're on call, or all night. it's like being a doctor. You know, same type of experience
Sure,
in many ways.
sure.
So you, so I went through clinical training at St. Mary's Hospital. Got most of my what they call a unit, clinical unit, and that's so many hours. I got 1,600 hours of clinical training as a chaplain and under supervision. You know, and I had a priest, Father Van Doren, up at St. Mary's Hospital in Green Bay, and I have 4 units of CPE, and that qualified me to go to the College of Chaplains and get certified, which I never did. It just, you know, because of limited jobs, you know, in the area, and I wanted to stay in the area because my wife was a teacher
Okay,
and my kids were young, so we decided to stay in Oshkosh.
okay.
So that's how. So how I ended up coming from Fond du Lac to Oshkosh was I took a job as a campus minister at UWO, the Gathering Place.
Okay,
I
sure.
don't know if you've heard of it or
I
not.
have, yep.
And I worked for United Ministries in Higher Education. So I worked for like 5 mainline denominations
Okay,
at the time. So and then I left that, and I was doing some part-time interim work at St. Paul's in town on West Side on 21 and Leonard Point Road
sure,
as a UCC pastor.
sure.
And I know Art Willie, who was like the executive minister, UCC. And then I ended up going back after my interim work to be their pastor. And I retired recently, about last May.
Okay,
What's the nationality of your last name?
It's it's either Russian Jew or Prussian.
Okay.
And I tease people about being like the wandering Jew.
Okay.
I'll tell you the reason why, because I grew up in the Catholic Church.
Okay.
My grandmother's from Ireland. You know, I went to parochial school.
Okay.
You know, I've had very traditional,
Me también.
yeah,
See.
experience. You know, I lived with my grandmother
Okay.
for a few years, and you know, parochial school. You know, went through all the rites of the Catholic Church. When I was about 16 years old, I left the Catholic Church. I was out on my own. I got hooked up with a minister who was very compassionate. I got kicked out of my house, basically, and I was on my own. I was emancipated
Okay,
minor.
that's all right.
Okay.
Yeah.
And then he took me in like he was like a real father figure for me, and ended up being involved in his church, which was in the city of Chicago, right by Wrigley Field, Aston Street Congregational Church, and basically grew up in the church. And he was my mentor, and you know, he helped a lot of people. He was like a black pastor in many ways, you know, where he ministered to the whole needs of people, and he's also a man of faith. So that I was very impressed. So I went to seminary, and I ended up graduating from seminary from an American Baptist seminary. So I took my first church and was ordained in the American Baptist.
okay. Well, and you know, one of the reasons I invited you on, Brian, was
Sure.
you know, we know each other first
Sure.
of all through our own church affiliation, but you know, we cannot presume that all of our viewers are spiritual or religious in any shape, form, or fashion. But I know because of your background, which thank you for sharing that, you have dealt with people from all walks of life, all faiths, non-faiths, and I thought because of that, you would be a good person to talk a little about, you know, how to deal with some of these things during the holiday season. I mean, let's face it, it's coming up faster than I think any of us would like to see it come up.
Yeah.
It always does, and this year in particular, people are dealing with a lot of stuff. You know, and I think probably the way, and correct me if I'm wrong on this, but the way people approach different losses and different grief in their life is probably dependent on, you know, their own personality and
Sure.
what they're specifically dealing with. So say someone is suffering the loss of a relationship or they're going through a divorce. You know, what's the best way to approach something like that, especially if there's kids involved? You know,
Sure.
Christmas is, you know, a happy time, Hanukkah is a happy time, and, you know, you don't want to be a downer with kids involved. How should people approach something like that?
Oh, I think, you know, as I look at my own personal life, and I think a big part of who we are and what we bring and helping other people out is our own experiences with dealing with changes in our life and process. And that's grief. You may, whatever terminology you might use on it, it's grief or dealing with changes and losses in your life. And I think the question is how do we, in a healthy way, deal with those changes in our lives? Sigmund Freud, after World War I, he saw the devastation and the death. He developed what they call the grief work theory of loss.
Grief work theory?
Yeah.
Okay.
And basically our attachment theory. It was a proper, theory. That you become attached, to your own lifestyle, your profession, you might say, certain things in your life, you sort of, this is the way it is. So what happens when all of a sudden this is interrupted, and there's changes, there's a death, there's a divorce, you lose your job. How do you adjust? And this is where he gets into the idea of, he said there's 3 concepts when it comes to the grief work process. You said the first process and the idea that grief is normal experience for human beings. You're not ill, you're not sick. It's how people deal with grief or loss or change in their lives, which you have to do. Secondly, you said that grief, you have to deal with the realities of that in your life, the losses and the changes. Can you accept what's the elephant in your room? In other words, let me explain that a little bit. Like in my own life, my mother, when I was 3 years old, she died. She was 24 when she died, and I found her dead. So it took me 36 years to really process my feelings. Holidays were not a good time for me, because of course it brings back memories of I didn't have a mother. And I denied it. Denial. Through my clinical process, going through my own training. And also, I think just timing. I think when people are ready to deal with change, you can't force people to deal with change. And you have to honor them and listen to them with your ears and, and what's going on in their lives and respect that. But being there, being present for people. But I think it took me, I can remember sitting in a show with my wife, and I was going through my clinical training at the time. Remember the movie Beaches with Barbara Hershey and Bev Miller? And my mother died. It was summer 1953. It's amazing how I remember. I was 3 years old. I remember this. Warm day, sunny day, took a nap, come out, my mother was on the floor. So I'm in the show with my wife, 30-some, 40-some years later, and Barbara Hershey, you hear this, somebody falling, and the little girl, who's a little older than I was, walks in the other room and finds her mother on the floor, dead. And I'm going, boom. And I'm there, and I'm in tears. It's like hit me right between the eyes, because I was overwhelmed, But in a way, it was a real catharsis for me, a beginning to say, I can deal with this and get on and move on with my life. And see, when there's, I think, when people need help is when they're stuck. They're stuck in destructive behaviors, and you can go through all your life not dealing with that, like I said, the elephant in the room, or that ball and chain, the emotional ball and chain that you carry around. Some people all their lives. And other times you can begin to find the courage to move on and deal with it and face it and move on with your life. So that, and that could be a job, doesn't have to be death. It can be anything. And some people shut down, as we well know, and they isolate themselves. And that's, that's not healthy, not really healthy. And I found, one thing I learned through my clinical training is that, 1,600 hours. The major thing I've learned about that training in the hospitals, Can you guess?
I can't, no.
You got any idea?
No.
Active listening skills.
Active listening skills.
Okay.
Well, that's what they were saying from the
Okay.
hospice
Yeah, yeah,
organization.
okay.
too.
Exactly.
Yeah.
Yep.
It's just amazing.
Uh-huh.
It's a little different than listening to people. I mean, I can remember as a pastor, you know, you greet people as they're leaving the church. Or somebody will ask you, a friend, say, well, how are you doing? But you can tell by those nonverbal cues whether they're looking at you, whether they're really interested in what you have to say and they're concerned, or they don't really care,
Yeah.
you know, and they're just saying it to be polite.
Give us an example of how that might work with active. I mean,
Okay,
play on me if you like. I mean, what?
sure.
Well, I'm got some problems here, but I really didn't want to come here. You know, what are you going to do for me?
Well, I'm glad I can sit down with you, and
Okay.
I appreciate you sharing with me.
Okay.
And I understand from what I hear you saying that you're wondering how I can help you
Yeah.
do this. I call that paraphrasing,
Okay.
okay, or clarification. Those are active listening skills, and it's part of it too is nonverbal cues.
Okay.
You know, am I looking at you eye to eye, or am I looking at the floor or somewhere else?
Okay.
And you know, am I sitting straight? You know, body language. You know, do I cross my legs? You know, is my foot moving? You can tell somebody was nervous.
Okay.
You know, when they, you know, there's different signs.
Their
Yeah,
foot's
yeah.
bouncing up and down.
Yeah, you know,
Yeah, you look pretty solid over
or
there.
they're going like, you know.
Yeah. Yeah. Yeah.
So,
All right.
so those are active
Yeah,
living.
okay.
And it just it amazed me when I was a chaplain that mostly, you know, instead of going into visiting people, I worked in oncology, hospice, med surgical floors, people in crisis, and it just surprised me time and time again. And I get this feedback from, you know, from patients a lot of times, or they're in evaluations, or they'd say this to me, or they come back later and say, you know, you did so much for me. You did so much for me. Well, I sat down and I listened to them. Active listening. And why I'm saying this, because I think when you talk about, you know, grief and loss and change, it's nice to know that we can go to somebody we trust, or even family members, and say, you know, this is how I'm feeling, and really know that they're really listening to you, and they really care about
really
what
important, isn't
you're saying. And I've seen some research in the past that shows how that, like when it comes to malpractice suits among doctors, that those doctors who have poor personal skills, interpersonal skills, and do not really listen to their patients are more highly likely to get sued for malpractice than those, you know, doctors who may not have the best technical clinical
makes sense,
skills.
doesn't it?
Yeah.
Yeah.
I mean,
Yeah, it does.
yeah. You don't care about me.
Or did you ever go in the doctor's office and you know, you're not feeling too good? You go in the doctor's office. You walk out of the office, all of a sudden you're feeling better. Do you ever ask yourself, why is that so sometimes? Maybe because you have a doctor who's sympathetic and says, yeah, I understand what you're saying. I know what's bothering you. I mean, that's the experience I've had.
Yeah.
I don't know
Sure.
if you've had that too, but
Yeah.
so that's why I'm saying that.
Yeah.
And the idea of stories, are so important. You know, whether you look at religious traditions, you look at mythology, Greek mythology, Egyptian mythology, any of the ancient civilizations. The idea of story is so important. You know, from oral tradition to written tradition, as we well know. And for example, I didn't know my mother. Then later on, when I was able to come to a point where I was ready to say to my older cousin, who knew my mother pretty well, and say, what was my mother like? What did she like to do? I learned so much about her through her stories. And for me, that was very healing in so many ways. And I encourage people, to ask the questions of saying, tell me about the person I loved, or this is what I'm going through, and this is my story. And listening to that story.
Sure.
An example, my mother. This is the only thing I have of my mother's.
Really?
This book. Bells on Their Toes is written by the author of Cheaper by the Dozen.
Okay.
This is from 1950, but if you want to
I do.
take a look at it.
While Dan's looking at that, and I
Yeah.
don't want to interrupt, but we're down to about 3 minutes, and I mean, this time is just going so fast.
Sure.
But you mentioned the word tradition, and
Yeah.
with so many people suffering loss of one way or another, one degree to another, should they continue to try to maintain the same kinds of traditions that they have in the past, or is it sometimes good to just develop some new traditions and start some new memories that maybe aren't so depressing in some cases?
I think you have to, it depends upon the person.
Okay.
Some old traditions are important. We met at Grandma's. We played this type of music during Christmas. Well, maybe for some people that'd be helpful. Maybe for others it'd be a disaster. It wouldn't be very helpful at all.
Sure.
And that's what I say. I'd say, well, it depends upon the person. And okay, what kind of new tradition could we celebrate in the memory of the person we love, for example?
Okay.
Or books. Like for children, how to help children, deal with changes. If you go to the library, there's. Do you ever hear the book Freddie the Leaf? It's an excellent book. Talks about changes, seasonal changes, to help little ones deal with changes in their lives. And there's books about getting divorced, moving, you name it. I think books are an excellent source. I think another source to help
Do you
people.
want to read what this says as far as what's the dedication on this book?
To mother who deserves better treatment. Isn't that the truth?
I don't know who that is.
Yeah, but I mean, it's,
Yeah.
it's such a, it fits your story.
Yeah.
Yeah. One other thing real quickly before
Yes.
we're out of time here, and this is more with the loss of disposable income.
Sure.
We always have to, it seems, we're always trying to keep up with the Joneses, and kids are under so much pressure to have the same thing that their classmates have and so forth. And with a lot of people suffering loss of disposable income in their homes this year, that may not be so easy to do. How should a parent, and I realize you're not a psychologist, but how should a parent best deal with this and explaining this to their kids that, look, we just can't do this year?
I think children are pretty tough. They can handle quite a bit. And I think the worst thing you can do is ignore children and not talk about what's going on in your home. Have a family meeting. Sit down and say, I'm sorry, kids, but this Christmas maybe we'll do something else. Get creative. Maybe go out as a family and help somebody else out.
That's that's always a good thing. It uplifts your spirits no matter what you're going through.
They say
someone else.
older people who volunteer live longer, for example. So there's a really a basis for that.
And also, if you're suffering a loss of whatever kind it might be, in particular a loss of life, whether it is a person or it is a pet, make a donation to some cause that is important to you, in their honor. That's
Definitely.
a good thing to do too. That makes you feel good, and at the same time you're helping out another cause.
Can I, Cheryl,
Just real quickly, because we've
Okay,
only got about
okay.
30 seconds left.
Okay. It's a matter of taking care of yourself too at this time of the year.
Okay, good point.
Exercise, diet, find things that give you nourishment spiritually, emotionally, psychologically. I think it's very important. Keeping healthy, because I've seen a lot of people who don't, and that can give big problems that way. But
Okay.
so
All right, excellent.
Self-care.
Very good. Brian, thanks so much for being
welcome.
here. It's been very enlightening. So,
Thanks.
Nice to meet you.
Thank you. And thanks to our guests from the first half hour talking about hospice. And that's going to do it for us. We will see you next time. Until then, take good care. Keep your eye on us. We've got our eye on Oshkosh.